partnership with Yorkshire Cancer Research and are very proud to collaborate with them on today's event. We're here to shine a light on innovation in cervical screening and also highlight some of the challenges. And we're very lucky to have an excellent group of speakers who will cover both a national and local perspective, and some excellent academic projects as well that have been recently getting some national interest. And it's great to have so many different people here on the event today. So we've got people representing GPs and primary care, academics, charities, cancer alliances and Public Health England and more. And by bringing together a diverse group and having an open discussion on the challenges and concerns and ideas, then hopefully we can explore future projects that Yorkshire Cancer Research and the HSN can support. As I mentioned before, once all the speakers are completed, there will be a Q&A session, so do add your questions into the chat function. And following that, we'd like to have an open discussion towards the end, so please don't be shy. Part of the value of today's event is by you offering your opinions, posing questions, highlighting areas that you think need focus, and ultimately, following today's event, we'd like to have a follow-up smaller event with a small group to discuss potential projects. And we should be all completed well before 4:30 today. So I'm sure many of you are already familiar with who the HSN are and what we do, but for those who are not, I just wanted to provide a very brief overview. The HSN is, well, the 15 HSNs across England, which was set up by NHS England in 2013 as the key innovation arm of the NHS. And we're a unique organisation with our strength that lies in the ability to operate locally because of the trust that our member organisations have in us. We understand the needs of our health system and are well placed to broker innovative solutions while collaborating across the whole of the country to take what works best and spread it nationally. Each AHSN works locally and benefits from being part of a national network. So we're embedded in the regional health and care community and understand the system and the patient needs on the ground. And this enables us to develop projects, programmes and initiatives that actually reflect the diversity of our local populations and the healthcare challenges. Everything we do is backed up by these three key aims: improving health and patient outcomes, driving down the cost of care and stimulating economic growth. And as well as the events like today, we have a diverse team working on delivering national projects on behalf of NHS England and NHSX, working on locally developed projects with our NHS partners. We're embedded in the region, in the region's ICSs to help support their innovation plans. And we literally support hundreds of companies every year with their progress to progress their solutions in the NHS to benefit the healthcare system. So what do we do? We're the catalyst for innovation and help facilitate change. We connect regional networks of NHS, academic organisations, local authority and industry. We create the right environment for innovators to work more effectively with the health and social care ecosystem. And we are collaborators. We identify successful innovations in our local and regional communities and support the spread of these across our network. And ultimately, that's why we're here today. As part of our commission from the Office of Life Science, we're committed to running showcase events like this one today to help achieve all these aims. And actually, this month is a very busy month for our team. We've got several events coming up which you might like to look out for. That includes a showcase on robotic process automation in the NHS on the 19th, a rehab-focused event on the 30th of March, and we're also supporting the West Yorkshire Innovation Festival with 2 events next week, and you can find out more details of those on our website. Ultimately, today's event is about showcasing innovation in cervical screening, so it's time to move over to move on to our expert panel of speakers. And we're going to start today's session with a national perspective from Simon from the Public Health England team. He's going to provide us an update on the national programme and some of the online tools that people can use to help them to understand issues and drive improvements. Simon, if you want to come off mute and start your presentation.
Thank you, Neil. Yep. So good afternoon, everyone, and thank you for the opportunity to speak today. Apologies for my colleague, Kate Storer, who was hoping to be here today, but not able to attend. So my name is Simon Rathall. I'm one of two cervical screening program development leads. We work in the screening division of Public Health England. So the role of Public Health England in the cervical screening program is to provide expert advice and to oversee quality assurance of the program. Next slide, please. Okay. So just to describe the scale of the program, cervical screening is available to women and people with a cervix aged 25 to 64 in England. So when I refer to women in this talk, I also mean those who may not identify as women but have a cervix. So over 15 million women in England are eligible to be invited for screening, and women aged 25 to 49 are invited every 3 years, and then every 5 years up to the age of 64. So in the last year reported, 4.6 million were invited for screening, and 3.2 million had a cervical screening test, normally taken in the GP setting. And you can note the screening years are like tax years, they run from April to March. And this data is actually taken from the annual cervical bulletin, which is published jointly by NHS Digital, who publish a lot of NHS data, and Public Health England, PHE. Next slide, please. So we know that nearly all cervical cancers are caused by certain high-risk strains of the human papillomavirus, or HPV. And after a successful pilot involving 6 laboratories across England, screening for high-risk strains of HPV was adopted as a primary cervical screening test in 2019. So by December 2019, all tests were being reported using HPV primary. Previously, HPV testing was used as a triage step for samples where abnormal cells had already been found under a microscope. So now samples are tested for HPV first and only then examined under a microscope. So this means a dramatic reduction in number of samples requiring cytology, such that now 8 laboratories process all the work for England. So those 3 million tests are handled by just 8 laboratories, and that's down from over 50 just a few years ago. Next slide, please. So the implementation of HPV primary screening in 2019 was one of the biggest changes in the history of the programme since it started in 1988. So it involved cooperation of the NHS, Public Health England, professional groups representing laboratory and colposcopy staff, and clinical professional groups had to be established to give guidance, and new pathways were required in the programme because the way women need to be managed through their screening journeys changes with HPV primary screening. And we're still working through the effects of those changes, and we're still developing guidance. Part of the reason why my role as a development lead is quite new this year. For example, we have things such as when somebody reaches the end of the screening program, so at age 64, but remains HPV positive, high risk HPV positive, how's the best way to handle them? And we need to make sure that people are being managed appropriately. Next slide, please. So there's ample evidence that HPV primary testing is a better test and more sensitive than cytology screening through the microscope alone. This means that the protection offered by a negative result can allow the programme to extend screening intervals. And so the UK National Screening Committee, which looks at all the screening programmes, have recommended that women aged 24.5 to 49, who would normally be invited 3 yearly, will move to a 5-year screening interval, and it's hoped that this will be implemented in 2022. So that means that women under 50 with a negative result would have their next test date set to 5 years ahead rather than 3 years now. And that would be a prospective change. We wouldn't change someone's screening interval based on a previous result. But this does rely on having a new call and recall system in place to handle these invitations and these extended screening intervals, and I'll discuss that a bit later in the talk. Next slide, please. I mentioned the U-screen here. I know Anita Lim is here talking about that, so just to mention in passing, because it's something that PhD have collaborated on, and I'll see Anita's talking about it later. So next slide, please. Just mention that U-screen, which is happening in London, PhD is also looking at a study to evaluate the viability of self-sampling across England, and the first step in that is happening now. We're looking to validate 3 different self-sample devices for use by women at home, and we're currently recruiting laboratories to take part in that study, and it will obviously also require involvement from colposcopy services and general practice, and that's something that we'll be looking at over the next year. Self-sampling obviously affect a big change in the program, and again would be something requiring a new call and recall system. The current call and recall system would not be able to handle that. Next slide, please. So just mention about sample taker training, because again that's something which PhD is involved in and had to be updated to reflect the HPV primary pathway. Assessments have been reviewed and updated to reflect primary screening, and including a popular e-learning which had over 10,000 unique users in the April 2019 to March 2020, and similar figures we've seen in the last year. Next slide. Just mention about some changes to the guidance for sample takers. So because of HPV primary again, we've introduced an interim assessment which a trainee must complete before starting unsupervised clinical practice. We brought in a minimum of 12 hours for initial training or theory course, including 3 hours practical classroom training, to allow the sample taker to practice technique on a pelvic model. And also, screening laboratories no longer provide feedback on trainee samples on their transformation zone or TZ sampling, because that's no longer used as a quality marker in HPV screening. And then the trainee must take 20 acceptable samples before a final clinical assessment. So I mentioned the call and recall system. So our current system, it's called NHAES, dates from the 1980s and is not fit for purpose in the modern program. I say that though, because obviously I've worked in the Cervical program for too long, and I've been told since I got here that NHAES was about to be replaced, and this year it would definitely have to change. And we were told when HPV testing first came along that it couldn't handle that, and it did, and HPV primary, and it's managed to handle that. So it stood a lot, but the problem now, it's getting difficult to support. The people who designed and worked on it are not in the program anymore, and one issue as well, it's actually made up of multiple boxes dotted around the country. I think there are about 80, and they're managed by the call and recall team. And so when women move around the country, their data has to be shuffled between boxes, which is obviously not very satisfactory, and makes it difficult to oversee. So NHSX are the new body. They were set up by Matt Hancock and are responsible for leading the digital transformation of the screening programs, as it's grandly put. And they've commissioned NHS Digital, who to undertake the transformation work with PhD in an advisory role. And we've spent a lot of time over recent months trying to ensure that the people developing the program understand the requirements of the program. Obviously, they're going to have to transfer all the data out the current system into the new system, make sure it gets there safely, make sure any unsuitable data or problematic data is handled, and then carry on. So it's a massive undertaking, and I think it's testing everyone's resolve. But I put on there spring summer 21. The latest I've heard is maybe more like the autumn, but there's a feeling it has to be done this year because there are other systems on NHAs which have to come off this year, and they want to get the cervical call and recall settled first. So we're hopeful that soon we'll have this new system, and that would be a single server for the country. It would take away a lot of the admin around moving people around. It would also be able to handle for people who are no longer on the system as female, but still need to be invited because they have a cervix, and which the current system cannot do. Next slide, please. Just talk about program standards and data. We obviously handle a lot of data from the cervical program. That comes from the call and recall system itself. It comes from laboratories. It comes from outpatient.
We appear to have lost Simon. Simon, can you hear us? Just bear with us a second while we have a minor issue. I don't think Simon's able to hear us, so we might have to skip on to the next speaker. Can people hear me? Just someone let me know.
Yeah.
Oh,
Yes.
yeah. Okay, that's great. So I'm not talking to my laptop. That's great. Let me just see if Simon's going to just return, because I just see his screen's gone black. So just bear with us one minute. Hello, Simon. Can you hear us?
Hi, am I back? Yeah. Sorry about that.
I don't know. You paused and then there was nothing.
Yeah. I'll turn my camera off just in case I've got some net bandwidth issues at this end.
Great.
You heard me talk about program standards and data, and to say we collect data from call and recall, laboratories, and colposcopy, which is the outpatients where when they're referred if they have abnormal screening. Last year we published our first annual report, and that's on gov.uk, and it shows performance for the year April 2018 to March 2019, and includes trend data where available. And it complements the annual bulletin, which is published jointly by NHS Digital and ourselves, which is more sort of bare tables. We try to create more of a discrete report. The next report is due this month. It will be different because gov.uk now wants us to do everything in HTML, in web looking like, so it can be seen on websites and that. So it will look a little bit different, but we're working on that now. And next slide, please. So just mention about coverage, because my final thing here to mention the coverage data tool. So coverage is proportion of eligible women with an adequate test result, and we tend to report two figures, one for young women who are invited every 3 years, and one for women over 50 invited every 5 years. And you can see on the screen, this shows for the last 5 years, and in 2019-20 we had coverage of 70.9% for the younger age group and 76%. Now both are below the 80%, which is what's seen as the threshold we should be reaching for a viable programme. But unfortunately, coverage has been below the standard since 2012. So many reasons, response to invitations, busy lives, etc. And there's been obviously work on initiatives. And for example, in 2019, there was the Be Clear on Cancer campaign, and we certainly did see a little uplift in coverage in the 2019-20 figures, which we believe was linked to that campaign. Unfortunately, in the last year, obviously COVID happened, which the programme didn't ever officially stop, but in practice, there was some cessation of services, and obviously people were not necessarily coming for screening. So we know we're several 100,000 probably samples down on what we would have expected in the year, and we have seen an uplift. And in fact, like February, which typically would not be that busy a month, we've had a lot of reports from laboratories that they're almost struggling because they are having to report so many samples. So we've definitely seen like a swing back up from that dip which we saw in 2020 as people do return for their screenings. Obviously that's great, that's happening, and hopefully that people do come and do come for their screen. And certainly it was a priority this time in the lockdown in January. It was a priority from NHS to say that screening was happening, and it shouldn't be, people should be allowed to book for tests. Next slide, please. So I'm going to try and take my life in my hands and share my screen so that I can show you our coverage data tool. And so this was developed. Hopefully everyone can see that.
Yeah, we can see that, Simon. Thank you.
Yeah. So this is on gov.uk. It goes up there quarterly. The latest one is on there now. It shows activity up till September 2020. It's the data actually comes on from the NHAIS system, the call and recall system, and it typically comes within about 2 months of. So this data was actually available in December. But what we do is we actually exchange this data with NHS Digital, because they get it from the system in a slightly different form. So we both work on it because they're publishing a report as well on coverage, and complementary to ours. And so what we do is we do an exchange. So we make sure that we get the same figures. We're happy with the data, and so this data here was released. It normally would have been released at the start of January, but it actually was delayed a little. Again, that's due with extra work with COVID and that, so we were a little bit slow. But what it does, it shows coverage at regional level. When I talk regions, I'm talking about at CCG level, and also by individual GPs. And in the period up to September, that's for about 7,000 practices across the 135 CCGs. Just excuse me. So mention that the number of CCGs has been reducing continually. So in April 2020, it reduced to 135 from previously 191. I think I've already seen it's going to reduce again in April this year, but of course also we've seen recent discussions that it's unclear whether CCGs will remain. I won't get into that discussion here, but just to say that has changed the data that we present as the number of CCG changes. So the largest CCG we've got is South East London, which is 440,000. Or if I put the two age ranges together, so over 500,000 women. And the smallest CCG is now West Lancashire, which is more about 24,000, 25,000 for the two age groups. And South East London has 218 practices in the CCG, whereas Surrey Health is just 8. So there's a big range in CCGs. They're very, very different. And the report also shows the coverage by age. So we can see that, for example, North Cumbria is nearly meeting the 80% threshold. East Riding of Yorkshire, another good. Yorkshire tends to be a good area in terms of coverage, but typically London tends to be at the other end, and we can see Central London down at 46%. And for the older age group, we can see Great Huddersfield, Nottingham and Nottinghamshire, again nearly at 80%. Liverpool, London, 60% or 60 plus. So if I show you the table, so if I pick a CCG, so let's pick East Riding of Yorkshire. So this top line shows you the performance for England as a whole. So we can see that there are nearly 10 million eligible women in the 25-49 age group. And the coverage figure for this, up to September 2020, was 68%. If we look at the north, what we count as the north, and we look at London, South, Midlands and East, and North. That's the regions we look at. And the North is made up of 52 CCGs, and a little bit higher than the English average, more like 71% and 76% for the older age group. And then for East Riding of Yorkshire, we can see 77% and 78%. So it's the second best CCG in the younger age group and the 6th best CCG in the older age group. And we can see these practices are all meeting the 80% threshold. And some good numbers, women get with adequate screens. One thing we do that's not relevant on this particular CCG is we suppress the smallest numbers. So if we have numbers of 5 or less, we don't actually show them in the report. I don't know if I can show that. One of these are coming out as having small numbers. Yeah, so just to show here, so there's a couple of practices here which we don't show because they're just the small numbers. So that's after something. So this is in like a table form. Let's pick another. So one thing it allows is the practice themselves can look at this and they can, for example, the figure here, it says if this practice had screened 12 more women within the 3.5 years, then they would have met the 80%. So it just gives a little sort of nudge about how close they are to actually meeting the 80% rate. We can also show this in a different form, show it more as a graph. So again, if I pick North and then let's look at Leads. So we can see we've got a few practices here which are exceeding 80%, a few close to 80%, and then just a few below. and we can select an individual practice, and it will flag where it is on the graph, just so we can see that, and also put the performance up. So it just, again, it's a little, just helps the practice to see where they are. I can't see how that's how all this is showing on your screen. So Neil, has that all been clear?
Yeah, that's been changing when you've made the selection. Yeah. So yes.
Great. So we release this every quarter, and it also shows the same practice can see where they were a year ago. So we can see though they were a year before they were over 80%, they've just dipped below here, but then they were only seven screens off meeting the 80%. So are very close to. And just say also, I put on the SDP that the CCG is part of, just so that's clear as well. Yes, so that brings into my presentation. So if anyone's got any questions on this, or do you want to save the questions till later?
I think we'll try and save the questions till later. Do you want to stop sharing your screen then, Simon, and we'll I'll start resharing mine. Just
thanks very much. Thank you.
Yeah, thank you, Simon. Just bear with me while I share my screen again. Okay. Right. So yeah, thank you again, Simon. It's been useful to get the overview of the programme and that useful data tool that people can use. And there's a link when we send out the slide pack. There is a link in Simon's slides that you'll be able to use to find that tool. So now it's time to hand over to Louise Flanagan from the Yorkshire Cancer Research Team, who's been key in helping me put together today's event. So over to you, Louise.
Thanks, Neil. So thanks for letting me speak today. So I'm Louise Flanagan. I'm one of two heads of services at Yorkshire Cancer Research, and one of the main focuses of my role is around screening, so increasing screening attendance across Yorkshire, and innovations in screening. So I'm really excited to be part of today's event. There's obviously a really great lineup of speakers, and hopefully it will lead to some more collaborations, because we're very keen to fund more work in this area. I'm particularly excited to hear from Anita and Claire later on, because we're particularly keen to fund some more work in the area of HPV self-sampling. So I might have a few questions for you later. But with all that in mind, I just wanted to talk to you today about who we are as a charity, a little bit about what we do, the kind of things we fund, and hopefully start some discussions about future collaborations. So who we are as a charity, we're Yorkshire's independent cancer charity, and we're dedicated to funding research so that people in Yorkshire live longer, healthier lives. Next slide, please. And why do we exist? Well, as a charity, we've been around for more than 90 years now, and we had a big strategy refresh back in 2015, and one of the things that was very clear from looking at the data at that time was that sadly more people in our region are likely to have their lives cut short by cancer than almost anywhere else in England. Next slide, please. So we know that Yorkshire has the third worst cancer outcome in England, with over 30,000 cancers diagnosed and over 13,000 cancer deaths in 2018. And there's also an estimated nearly 200,000 people in 2018 were living with or beyond cancer in Yorkshire. So we know that there's a big problem in our region for various reasons. Next slide, please. So our aim as a charity is that we have 2,000 more people surviving cancer in Yorkshire each year by 2025. And where this figure came from, this was really driven by the data we looked at back in 2015 when we had a big strategy refresh. And we looked at the best performing CCGs across the country. And if we scaled up the kind of figures that they had, we would see 2,000 fewer deaths across Yorkshire. Next slide, please. So what we do in order to reach those 2,000 more lives, we fund research and services in 4 key areas. So prevention, where we fund work around screening would come into that, but also physical activity programs, early diagnosis, obviously around screening, improvement in treatment. We have a big research funding pot for clinical trial research, and improving survival, where really all of those things are encompassed. So earlier diagnosis, better treatment, and physical activity again. Next slide, please. So this is a little bit of a busy slide, but it just really shows how we're trying to get to those 2,000 lives by 2025. And like I said, we're funding research and services across the board. But for the purposes of today, if we're looking at screening and early diagnosis and prevention, so we want to get 60,000 more people up to date with at least one national screening programme in Yorkshire, which will then feed into our KPIs in terms of the number of lives that would save. Next slide, please. So if we look at screening within Yorkshire, as some of Simon's data just showed in the talk before, we actually don't do too badly in Yorkshire if you look at it as a whole area, just compared to England averages. But we know that that's not the case on a kind of CCG, on a GP level. And if we drill down into the data a bit more, next slide, please. We know that there's significant variation in screening participation in different GP practices in different areas across the county. And although looking at Yorkshire as a whole, cervical screening does quite well compared to the England average and is quite close to the 80% target, we know that it varies between 20% and 90%. And obviously the areas where it is much lower are of a concern to us, and that's where we want to do more work. And we know that deprivation is an issue for Yorkshire, and the most deprived areas in Yorkshire are among some of the most deprived in England. And cervical screening coverage has the strongest relationship with area deprivation. So we know that the worst performing CCGs for cervical screening in Yorkshire are also among the most deprived areas. Next slide, please. So just to talk to you now a little bit about what we fund, particularly in the cervical screening area. Like I said, what we fund is quite broad in terms of our clinical research and our services, but specifically within cervical screening, there's just a couple of programmes that I wanted to highlight to you today. Next slide, please. So one of these was the Wakefield GP screening project. So this is something that's just coming to a close at the moment, and we're just waiting on the final evaluation. But what we funded here was we worked with Wakefield CCG, Wakefield Council and the Health Alliance. And the aim of the programme was to increase screening uptake across the city. So this was done within GP setting, and we worked with 12 GP practices across the city. And we funded 3 cancer facilitators who went into those GP practices, and they would deliver a number of different interventions. So letters, texts, phone calls, conversations with non-responders, to encourage them to take up their screening invite. We are just waiting on the evaluation for this, but the initial data looks really positive in terms of the percentage increase that they've seen in those practices compared to the practices that didn't take part. And they're actually just putting together an application to fund an extension to this, whereby they'll go into the other GP practices across the city to hopefully replicate that and replicate that improvement in screening across Wakefield. Next slide, please. And the other programme that I wanted to just touch on today is Cancerwise Leads, and you'll hear a bit more about the innovative work that the team are doing from Lisa and Alex in the next presentation. So just to kind of cover this broadly, so this is working with Leeds City Council. And again, the aim is increasing screening rates across the city. And this is a bit more of a broader scope than the Wakefield GP screening. So the team are going to be working across all GP practices in the city. And that's going to be done through a network of 10 coordinators, Lisa and Alex being 2 of them, who you're going to hear from in a little bit. And again, it's focusing on the needs of particular areas. So there's obviously within Leeds some very deprived areas. So focusing on improving the health of people living within those deprived areas and vulnerable populations primarily, but we will be looking at the city as a whole and the kind of interventions that can be put in place to increase screening rates. So this differs from the Wakefield GP screening programme in that it's not just one intervention. So within Wakefield, it was the letters, the texts and the phone calls, but this is really looking at things on more of a hyper-localised basis, and you'll hear some of that from Lisa and Alex shortly. Next slide, please. So really just to reiterate what we do as a charity and what we want to fund going forward. So I'm very keen that out of today, we can start some conversations about potential new funding for whether it be research or whether it's services in this area. You've seen examples of the things we've funded currently within the cervical screening arena, and that's something that we want to continue to fund across Yorkshire, but also innovations. So we're very keen to fund work on HPV self-sampling and any other innovations that people are keen to put to us. So that's my email address. If you're interested to hear a little bit more about what the charity does, there's our newsletter will be going out with the meeting pack, and I'll also post a link in the chat for how you can sign up for that newsletter, so you can hear about the work that we're doing currently and the kind of things that we want to do going forward. And that's it from me.
Louise, yeah, as Louise mentioned, key to today is input from everyone on at the event today. So again, I would really just encourage any comments or questions that you want to pose in the chat, or when we have the discussion at the end, that you put forward any opinions or challenges that you think we need to discuss. So next up is Lisa and Alex from the Leeds Cancerwise team. I think, Lisa, you're going to share your own screen.
Yes, please, Neil. Thank you.
She'll stop sharing mine, and you can hopefully go ahead.
Okay, yep. Can you see that okay?
Yeah, we can see that. Yeah.
Brilliant. Thank you very much, and thanks Louise for that. Yeah, my name's Lisa, and I'm going to be co-presenting today with Alex, and we are two of a team of 9 screening and awareness coordinators that work within Leeds within specific primary care networks. What we're going to talk to you today is about a couple of pieces of innovative work that we've been working on in relation to cervical screening and how this is working to increase screening in certain populations. So the PCN that we're looking at today is Bramley, Wortley and Middleton, and for the purposes of this presentation we'll refer to that as BWM. And as you can see from this slide, it is one of the most deprived areas in the city, and you can see there that smoking, obesity and diabetes are all higher than the city average, which we know are contributing factors when it comes to looking at cancer. So before we talk to you about the work that we've been doing, we just wanted to we'll trial this, an interactive exercise with you all around what you think are the main barriers to cervical screening. So we've asked this question to some of our populations, and we just want to get a flavour really from the rest of you, whether you are coming across the same barriers as we are, and we can have a little chat about that. So if you're not familiar with Menti, if you have a smartphone, you can just type in menti.com and then use the code 51730206, or you can just use your laptop or whatever you're working on, and again just do the same thing. And I'll just give you a couple of minutes, hopefully this works, and then some of your answers will come into this, and we will share these slides at the end as Neil said, so we can share all our findings together. So yeah, hopefully this works and you're brilliant. Some of your answers are coming up here now. So I'll give you a few more minutes and then I'll pass over to Alex, who will talk to you about the beginnings of this project and how it all came about.
Thank you, Lisa. Just having a look at them all coming in. Hi everyone, I'm Alex. So just seeing them all coming in now. Cultural issues, yep. Embarrassment, language, anxiety, yep. Awareness, inconvenient appointments, getting time off work, disability. Wow, they're flying in now. They keep moving. So I'll just give you a few more seconds, give you 10, 20 seconds, let's have a see. Knowledge is coming up quite a lot, embarrassment, language. No, that's brilliant. Thank you everyone for the input. Some of these, the things that, as I'm looking at them, they are barriers that we have come across in our work, and this understanding, knowledge, awareness, anxiety, embarrassment, inconvenient appointments, and getting time off work, that resonates quite closely with our project. And one I haven't seen yet, but I think it's one that I don't know if it's affected everyone the same, but what we have noticed in Leeds is COVID itself becoming a bit of a barrier to attending appointments. The work we do in our projects was to support PCNs to increase uptake in these groups of women, in particular with cervical screening, patients who aren't attending cervical screening appointments. But what we found is that some patients that were attending before are not attending now due to COVID. So this is something that we have seen, and it's very interesting, and it's something we have looked into, and Lisa will be discussing how we've looked into this later into the presentation. But thank you for these inputs, they're amazing. So what we'll do is I'll go through how we've got through this project, how it came about, and the work we did to get there. So
We began early January last year in 2020, where we had discussions with the BWM PCN around areas of focus that we wanted to look on to help support them with uptake in screening. And we decided collaboratively to look specifically at cervical screening within that PCN due to low uptake in that area. So to do this, what we did was we did in-depth data analysis for each individual practice, looked at them separately, but also collated the information to look at the PCN as a whole. And we broke down the data to look at age, area, ethnicity, but we also wanted to look into the uptake within specific groups, such as people who are SMI registered and on the LD register as well. So this is something we did, as I say, back in January, so things are slightly different. So before we show you the results of what we found, we just wanted to gauge from yourselves. This should now have slid, if you've used Mentimeter, it should have now gone on to this, I think, to this page. So we just wanted to see which age group you think we found was the highest number of non-attenders for cervical screening. So it should be on the next slide for your voting buttons. Oh, yep, they're already sliding in. And I'll give you a few seconds, just to look into that. Yeah, oh, yep, they're flying in. There's a lot going, 25 to 29, a couple in the 30 to 34 and 39, or 35 to 39. Yep. I'll give you a few more seconds. Right, so yeah, that's very interesting. So if you said 25 to 29 age group, but I can, the majority of you did say that, and 30, there's quite a couple, the 60 to 64 as well. That's interesting. But if we go on to the next slide, we'll see. If you said 25 to 29, that was our lowest uptake for cervical screening by age group in the PCN, which is marked in purple. For this project, however, because we decided to look at the age group 25 to 29 in a separate piece of work, because these are women who are potentially, this is the age group of women who have had the HPV vaccine, and are also women who are coming up for first screening they have had. So we wanted to do a separate piece of work in terms of pre-25 work and preparation for women in that. So what we did decide to look at is that, as you can see here in the blue columns, the 35 to 49 age range is still a high percentage of people who are not attending their cervical screening appointments. And what we wanted to do is really focus in why this age group were not attending cervical screening appointments. So taking this data to the PCN, what we decided as the next step was to do a survey of these women, patients, in the 35 to 50 age group, 2 surgeries. We took a list of non-attenders that we had that had not attended as yet for their screening, and we called them, asking them why they hadn't attended the screening, if they wanted to book in. A few women said that they'd just not got round to it as of yet. It's something that slipped their mind, but a lot of the women we spoke to and patients we spoke to said that it was, some of the major barriers for them was time and accessibility of appointments, specifically due to childcare, work arrangements, the time taken out to go to your appointment and go back to work. And it just was difficult for them to find time to do that. So following on from this survey, we went back to the PCN to set up and decide what our actions would be going forward. So in February, March time, we came up with an action plan, and as a PCN decided that this lack of appointments during convenient times, and when asked, actually, I've got to say that when we asked women, would a weekend appointment be more preferable, they said yes. This is something that would, it's easier for them to get to in terms of time doing the daily work and childcare responsibilities. So decided to put on, as a PCN as a whole, a cervical screening hub on a Saturday morning. Now, this was the plan initially was to go ahead and set up this clinic for April, but due to COVID coming at the end of March, these plans had to be put on hold, and the halting of screening invitations going out, and although we were still doing cervical screening appointments, the screening invitations had stopped, and focuses we're trying to make GP surgery safe for COVID. So we did put that work on hold until June. So in June time, with the restart of cervical screening, we came back and looked into this option of setting up this hub within Bramley-Wortley PCN. So what we did was we linked in with our extended access team. Now, the extended access team supported the PCN and ourselves in setting up the clinic. They looked in terms of the best location for the clinic, the timings of the appointments, staffing for the clinic, and the amount of appointments available for the clinic. So this was tackling the barriers, you know, that some of the barriers that that you said as well, you know, that came from the women, this lack of appointments at available times, access, and childcare, which Lisa will go on to just explain a bit further as we set this up. So I'll just pass on to Lisa now, but before I do, since we've set up this clinic, this cervical screening hub, extended access, and the Leads, we've set up 14 hubs on a weekend that are providing nursing screening appointments, which is just amazing. So from this project, we're now at we should be they've either started or in the process of starting at 14 of our PCNs across the city. So it's really amazing, exciting that this piece of work has kind of spread across the city. So we're hoping, you know, potentially this will grow, and that it's more access for appointments for all women across the city. So I'll pass to Lisa now to explain the launch of the hub.
Thanks, Alex. Yeah, this has been taken as an example of best practice in Leeds. So like Alex said, there's now 13 or 14 hubs being set up, which is incredible. Ours was set up in September 2020. So it's fairly new. They're still finding their feet, but we're seeing that the attendance rates are actually increasing month on month, which is really, really good. And what you can see from here, and it's some more data, but it's just showing you that obviously the 25 to 29, Alex has alluded to the fact that we are aware these people aren't attending, this age group aren't attending. They do seem to be, from this graph, they do seem to be actually booking into the hub. There's a fairly high DNA rate with those. So we are looking at that again as a separate piece of work. So other than that, when we look at the age group 30 to 39, it's really encouraging to see that they're actually utilising the hub, because that is who this was set up for. And we've also heard anecdotally from practice managers, screening champions and other staff within the hubs that the people that are attending are actually telling them that they're the ones that couldn't get appointments during the week, so they're attending on weekends because of childcare and work. So that's fantastic. And again, it's showing that we're highlighting and targeting the right patients. So those that would usually find it hard to attend. Okay, so we have alluded to this before around COVID, and I know Simon talked about it in his presentation as well. There has been issues around people coming for screening due to COVID. So we're not only looking at those people that are finding it hard to access clinics and attending, we're also looking at building in confidence in people to return back to practices for appointments. So again, we've adapted our work because of this, and we held focus groups in July to gain an understanding of how people were feeling as cervical screening was being reintroduced. And we put together, along with our communications team lead, some key messages around screening to ensure that we are reassuring people that it's safe to attend. So we created messages and we created images, and we circulated them out to all of our key contacts throughout the primary care networks so that they could use them within their bulletins and other correspondence. And another piece of work that we have done recently is create a walk-in of someone accessing a cervical screening hub. So it's showing them what happens when they attend the hub in terms of hand sanitizer, what to expect with spacing in waiting rooms. And it's really, again, just to reassure patients that it's safe to attend and encourage them to come in for practice. We did create this initially just for the BWM hub, but then we saw that actually it was needed across the city. The barriers that we were seeing were the same across the city. So we created a generic version to use for them. And then following this, we wanted to make it more accessible. So we did a piece of work looking at what are the common languages that are spoken in Leeds. And we have since then have now had the video subtitled in Urdu and Polish, which is fabulous. So these can all be found on our YouTube site, which is Cancerwise Leads. And we have short versions, short edits you can see on this slide, and they are about 20 seconds long. So it's just a bit of a taster into the video. And these are fantastic for social media. And then we have the longer edits, which are great to be embedded onto websites. And the majority of our practices have actually embedded this into their social media and websites. So it's another way that we're trying to raise awareness and adapt our approach because of COVID. So the image on the left is just an example of what we have created since the focus group to sort of show people, well, just adapt really to the current situation and show them about the 2 metre space in hand sanitizer and that it's safe to come to practice. And I'm going to show you just a 20-second clip of the generic version of the video. And apologies in advance, this software doesn't allow us to have audio. So this is where the subtitles come in really handily so you can see how they work. So I'll just show you this. Hopefully this will work. Okay, so I just hope that's given you a flavour of some of the work that the Cancer Screening and Awareness coordinators have been doing. And I just want to say thank you so much for inviting us along to talk today. And if you want to ask us any more questions or want any more information, then our email addresses are there. Also, just to say that we have got a practice nurse and a screening champion that's joined the call as well, Jill Rigg. So she's fantastic and she works on the ground doing some of the work that we've implemented. So again, if we've got any questions, we can pass them on to her as well. So thank you very much.
Thank you.
Thanks, Lisa. Thanks, Alex. That was great. I'll just start sharing my screen again and we can carry on. Bear with me. Okay, great. Well, thank you, Lisa. Thank you, Alex. It was great to hear about that project. And really interesting to see how you're improving uptake. And I really like that interactive element with the Mentimeter. That was really good. So we've had a bit of a Yorkshire focus so far, but now we'll be hearing from some really exciting projects from outside of the region, and they're likely to impact us in the future. So we're very lucky to have Dr. Anita Lim from the Uscreen programme in London. And she's going to provide us an update on the project she's working on. So Anita, over to you.
Thank you. Thanks, Neil, and thank you for inviting me to speak here today. So hi, everyone. I'm Dr. Anita Lim. I'm a senior epidemiologist from the Cancer Prevention Group at King's College London. I'm going to be telling you about the Uscreen study, which is a study that was funded a few years ago now. Actually, it was funded back in April 2018 by the UCLH Cancer Collaborative, who were at the time a cancer vanguard. And the reason why they funded it is because, as like Yorkshire, they were very keen to introduce cell sampling to improve cervical screening in their patches. So in North, Central and East London, they've got some of the worst performers for cervical screening in the country. So next slide, please. Let's just start with the study's rationale. So London has consistently got the lowest coverage in London, as we heard earlier from the PHE data, and this has been going on for quite some time. And this is this is really in spite of continued investment to drive uptake. And in some areas, we've got almost half of women not coming. Next slide, please. So the rationale for U-screen is very clear. We know that underscreened women are at the highest risk of developing cervical cancer. So it's really important that we get our coverage up. In terms of screening barriers, we've just heard a bit about them in the presentation before, but what the research shows is that women, we know that lots of women don't come because they have a fear or dislike of the pelvic examination or the speculum. There might be cultural or religious reasons or social taboo why women don't come. And there's also practical barriers such as difficulty getting appointments and busy lifestyles. And these sorts of practical barriers, we presume that they're actually really even more important in big cities like London, where it can be really difficult to get appointments. And also there was some work by Dr. Jo Waller in our group who showed that it's actually, while lots of women will actually say that they don't, they have a fear or they feel embarrassed about it, what's actually most predictive of screening behaviour is the practical barriers, busy lifestyles, lack of time, etc. So fortunately, self-sampling is something that can really address most of these barriers. And studies have already shown that self-sampling increases uptake in non-attenders, and this is generally seen across all socio-demographic groups, which means that self-sampling hopefully will start to address inequalities that we do see in screening. And the research also really shows that it's very acceptable to women, so women really like it. And if you ask them, many of them will say that they prefer it over clinician sampling. Next slide. So what exactly is self-sampling? So most of you will be aware, and you would have heard just earlier, that this country has moved from cytology testing to HPV primary testing. Now, one of the advantages of HPV testing is that, unlike with cytology, you don't need to have intact cervical cells in order to get a good sample, because the HPV virus will spread from the cervix into the genital tract, and that enables vaginal material to be self-collected by women. So self-sampling allows women to take a sample themselves in private and in a time and place of their choosing, and they don't need an appointment and they don't need to be examined. And this is why it's really addressing all the screening barriers that I've mentioned earlier, although there's some obviously that it doesn't cover in terms of things like low awareness. Now, women, never mind. So self-sampling, so I've got a bit more to say in the previous slide, but there's no material to support that. But really just to say that self-sampling, what women will get is they get a kit that contains everything that they need to collect and return their sample. And samples for vaginal self-sampling, they're typically taken with a little swab or a brush. So women would collect their sample at home or in the bathroom in clinics, like, or behind a curtain in the clinic room. So that's why we've got this in GP primary care, and they'll post them directly to the laboratory for analysis. So in terms of the self-sample test accuracy, we know that self-samples actually have very similar accuracy to clinician or nurse taken samples for detecting SIN2+. So meta-analysis of 56 accuracy studies shows that self-samples are as sensitive, meaning that they're able to pick up and identify those with disease well, and slightly less specific, meaning that that's their ability to correctly identify those who don't have disease. And so that's similarly sensitive and slightly less specific than clinician taken samples if you're using a particular type of assay, which we are, so that's a PCR based HPV assay. So the key message here really though is that self-samples are reliable and effective for cervical screening, so that's not in question. There's really robust evidence around that now. Next slide, please. So in terms of the aims of U-Screen, our ambition really is to test the end-to-end pathways for introducing self-sampling for non-attenders within the NHS cervical screening programme. So we wanted to generate lessons to ensure a smooth transition for a national or a London-wide rollout, and to start to provide the evidence base for how best to implement self-sampling at scale in England. We also want to estimate the expected increase in uptake and coverage associated with offering self-sampling, and this includes the SIN2+ detection rates that we would get. So what we did with the study is we really recognised that one of the key challenges of introducing new tests into a call recall based program is establishing the robust pathways for accurately identifying the relevant population, recording and reporting these test results, and setting the correct recall intervals. And we felt that London would be an ideal testing ground for this new self-sampling pathway, given its long-standing issues with coverage. So next slide, please. The U-Screen design U-Screen is a pragmatic implementation feasibility clinical trial of offering HPV self-sampling to cervical screening non-attenders within the NHS cervical screening program. So what this is as a study is it marks the first time that we've ever offered self-sampling under the program and as part of the NHS. So all the studies that have been carried out before, the self-samples have not counted on the screening program. They've not been recorded within the screening program. So it's a landmark study in this sense. So our target population is women, aged people with the cervix age 25 to 64 who are eligible for cervical screening, and they must be at least 6 months overdue. The self-sampling device itself is a flop swab, so you can see it pictured here. It's a really simple device, something that's used quite often for STI checks. It's going to be transported dry and it's at room temperature, so it doesn't need any special storage conditions. All the testing is being carried out by the London laboratory for the screening program, so this is CSL, and they'll be analysed by the Roche Cobas 4800 machine. So in terms of the study duration, we plan to be recruiting women over a 12-month period, but we may end earlier if we hit our target number of women a bit earlier. Next slide, please. So in terms of the setting, we've included the 5 boroughs across North Central and East London, which is where the funding came from, with the lowest cervical screening coverage. So this is Camden, Islington, Barnet, Newham and Tower Hamlets. And what we did is that we invited all GP practices to take part, and we thought that we'd get about 100 GP practices that would be interested and that would sign up. And what we actually ended up getting was 165 GP practices in signing up within 2 weeks. And so we did this, you know, we were already in lockdown by the time we got to doing this. And so we were pleasantly surprised, but I think this really just indicates what a huge appetite there is for self-sampling. Next slide, please. So for Uscreen, we're offering kits in 2 different ways. So these are 2 different pathways, but all GP practices who take part will be offering both pathways. So the first is really a systematic approach, which is a direct mail out. So each month, women who reach the 15-month anniversary of their last test due date without being screened are identified by the screening program, and they're sent a pre-notification letter. So they get sent a letter via CSAS, which is the normal pathway, so it's kept within the program. And then about a week later, they're receiving a kit in the post from a commercial kit company. And that pre-notification letter is really, we just did that so that women aren't receiving a kit out of the blue. And we hope that would, you know, increase the likelihood of them returning that sample and not thinking it's junk mail. So the second offer is an opportunistic offer in GP primary care. So women who are at least 6 months overdue for their screening according to their GP record are automatically flagged by the GP software. So all the practices in the study are using EMIS. So what we've done is we've asked GPs, nurses and healthcare assistants to offer women who are flagged by the GP system as eligible a kit when they consult for any reason, and this should be a non-screening reason. So if someone turns up for a sore toe, and you can see that they're overdue their smear with their screening, then you can, if they're eligible, they'll be flagged and you can offer them the kit at the time to see if they would like to take the offer. So if women are offered a kit in the clinic, they do have the choice of taking that sample in the clinic, or they can take that home and then they'll just post it back to the lab. So we've estimated that we'd get about probably 31,000 kits given out in total for the study, and we've estimated we'll probably get about 10,000 returned. Next slide, please. So this is just to show you the timing of the Uscreen kit offer so that you can conceptualize it. So this is the core recall pathway. Women are invited every 3 to 5 years, depending on age. So if they're 25 to 49, they get invited every 3 years. Women aged 50 to 64 are invited every 5 years. Now, at 3 months' time past the invitation, they're going to get a reminder letter. After this, they haven't responded, and the 6-month mark, you can see that they've clearly ignored their invitation and the reminder, ignored and not gotten around to, if you'd like to view that, but they haven't turned up, so we consider them to be overdue. Now, the 15-month mark has been selected, and this is selected so that it avoids the core recall reminders and the next invitation. So it's a really distinct offer, and that it's clear to women that this isn't another reminder and that we're really offering them something different. Next slide, please. So the Uscreen kit contains everything that women need to collect and return their sample. So they get written pictorial instructions for how to take their sample, a patient information leaflet so they understand all about the study. They get a free post envelope, which is pre-addressed to the lab so that they can just send their sample back to the lab, and they can just drop that into any Royal Mail post box. And there's also a short survey which has been designed by behavioural scientist Dr. Joe Waller, who I brought up before. And this is really seeking to find out more about the women who take up the offer of self-sampling and their previous barriers to participation and their future screening intentions. Next slide, please. So this is our clinical pathway. The vast majority of women will test HPV negative on a self-sample. So we're expecting about 85% of women are going to test HPV negative, and these women will just simply be invited at their next test due date, which will be routine screening in 3 or 5 years, depending on age, and they will be ceased if they're age 60 above and meet the ceasing criteria. Next slide, please. So there will be a handful of women who test HPV positive on a self-sample, so that we are estimating it'll be around the 15% mark. So for these women, in their results letter, they'll be advised to book in for a follow-up test, and that this will be a conventional screening test taken by a doctor or nurse. So in this case, it will be the HPV primary screening test, and then they will be managed according to that result under the program. So there's a number of safety nets that we've got in, because partly, you know, a lot to do with the fact that this is a study. So within the program, these women will be set to a 3-month recall, meaning that they will, if they haven't turned up for that follow-up appointment within 3 months, they will get they'll be sent a reminder letter, and then they'll get another reminder letter, so they'll be part of the usual call recall process. And also the GP practices will be asked to contact them. And actually, because of COVID at the moment, what we're doing is we're asking GP practices who take part to actually, as those results come in, they do receive the results via the usual electronic pathways for cervical screening, and we've asked that they actually contact the woman to help them book in for that follow-up test at the moment, because we understand that it might be difficult for them to get screening appointments under the circumstances. So that's what we've got for that pathway at the moment. And also, you might be interested to hear that actually studies show that the compliance to follow up for self-sample positives is actually very high. So in meta-analysis, on average, it's 81% of women will actually turn up for that follow-up test. So that is something that people get concerned about, that if you test HPV positive, but you know, what are they not coming back? But they do come back, and I would assume that that's probably a lot to do with once you've got a positive result, an abnormal test result, you're much more motivated to go and get that followed up. But with obviously a huge interest to see how this turns out in more of a screening program setting. Okay, next slide. So there's going to be a small proportion of women who will have HPV unavailable. So what this means is that there's insufficient DNA that's been detected on their sample in order to give a valid result. So this, again, this is quite rare. We're expecting that to be in the region of less than 1%. But all that's going to happen for these women is that they will just be simply set a repeat kit out in the post. And based on previous studies, we know that most women seem to do this quite happily. Next slide, please. So in addition to the impact of self-sampling on uptake and coverage, there's quite a few other things that we want to learn from Uscreen, which I haven't had time to go through today. For example, we are going to be looking at cost effectiveness, and also we hope to be really getting rich and detailed information about the profile of women who return a self-sample. So we're collecting ethnicity data, which should be quite exciting to look at, really, because it's quite rare that we get the opportunity to look at that within this context. But ultimately, what we learn from Uscreen should lead to a faster implementation of self-sampling, we hope, and to better planning locally. So this is the current timeline that we're working to. We've started in January this year, which was a huge push on behalf of the, you know, it's taken a lot of effort to get to this point for various reasons, notwithstanding the lockdown. So it's great that we started. We're going to do up to 12 months of recruitment, and we hope to report on the results mid-2022. Next slide, please. So I really just wanted to acknowledge everyone who's worked on the Uscreen project, because it has been a huge piece of work, and there's a lot of people that have been involved, including PHE, NHS England, London, and Joe's Cervical Cancer Trust. So just to acknowledge their work, and thank you for your attention.
Thanks, Anita. That was great, and we look forward to seeing the results next year. Again, Again, if you've got any questions, please do add them in the chat or save them to the end for when we'll pose them to the panel. So do have a think about questions you might want to ask to the team. Now we've got a final presentation from Claire Gillam from the London School of Hygiene and Tropical Medicine with another HPV project that she's been working on. Hi, Claire.
Hi everybody. Thank you for inviting me today to present this. I'm presenting an editorial that's just been published in the British Journal of British Medical Journal, and in a nutshell, there are 6.5 million women aged over 65 who have already ceased the screening programme. So they would have been screened with cytology screening before the implementation of HPV primary screening. And what I'm proposing is that we should offer these women a catch-up test. Next slide, please. So some background on cancer incidence and mortality in the UK. The bars on this chart shows cancer cases every year, and the red line shows cancer deaths. And you can see, I'm sure that this is well known, that the high incidence in young women are lots of cancer cases that are picked up through screening, so they're diagnosed early, and the mortality is very low in this population because screening's working, it's doing what it's meant to be done. But the purple bars are cancer cases in the population that I'm talking about today, and these are women that have ceased screening, so they're aged over 65, and they account for about 18% of the cases, but they account for 46% of the deaths. And also you can see that as women get older, so women in their 80s, the ratio of incidence to mortality is almost 1-to-1. Next slide, please. So I've used data from the National Case Control Study to split up the 6.5 million women by their screening history when they were aged 50 to 64. And I've also done the same for the 5,000 cervical cancer deaths that I've estimated will occur within this cohort of 6.5 million women. So now each colour represents different screening history. So there's about 1 million women in green who have no screening, and they account for a large chunk, so about 40% of the deaths. So these obviously should be a target because they are at particularly high risk. There's also a very small proportion in sort of a pinky colour of 0.3 million women who have had some sort of abnormality between the ages of 60 and between 50 and 64, so before they cease the programme. Now most of those should, I say should, have been followed up and should have exited the screening programme with a negative test. And there'd be a mixture, basically, this group. But in absolute terms, the purple group are those that have all exited the screening programme with a negative cytology. So they've had at least one negative cytology between the ages of 50 and 64. And actually they account for the largest proportion of future cervical cancer deaths. Next slide. So I wanted to talk to you about what they've done in Denmark. In 2017, all women aged 69 were invited for a primary screening test. So this was to attend their GP surgery to have a cervical test taken. So they were invited by email or post, but they were just invited just once and no reminders. But overall, they achieved a 30% response rate. But you can see that it declines, as you might expect. It declines, rapidly with age. And overall, they found a 4% prevalence of HPV. So 4% of them tested high risk HPV positive. Next slide. So this shows the histology in those HPV positive women, and nearly 20% were found to have some sort of abnormality, and 11% had SIN2+, and they found 37 cancers, which equates to 0.8%. Now, unfortunately, they haven't published any results by screening history or HPV genotype, so we can't extrapolate too much, but the screening program in Denmark is fairly similar to the screening program here. So based on the fact that we've got, our population is about 15 times larger than Denmark. So what does this tell us? Basically, what can we learn from this if we were to roll out a similar catch-up program in the UK? Next slide. So these numbers here, these are really rough calculations, back of the envelope calculations for the whole of the UK, and also I've added a column for the Yorkshire region as well. So if every woman aged over 65 were to do an HPV test, we would estimate that there's roughly 220,000 HPV positive women in the country. And based on the Danish results, about 24,000 would have SIN2+ that would require treatment at least. And this would equate to about 1,800 prevalent cervical cancers. But there will also be future cancers and deaths that would have occurred in this population. So, you know, how could they be picked up as well by this single test? Now, for a start, 24,000 of them at least would be treated. So one would hope that that would prevent a large proportion of future cases. Next slide, please. But how good a catch-up program is at preventing future deaths depends on three things. So first of all, coverage. I think we could do, well, we could do certainly a lot better than 30% response rate in the Danish study. First of all, older women don't, they often don't see themselves to be at a particularly high risk of cervical cancer. So improving excuse me, the education in these women and explaining to them the risks would be a first idea. And then secondly, self-testing. And as Anita has said, you know, it's highly accepted by women. It avoids the potentially painful speculum exam by older women, and even in Denmark there were, you know, fairly high, you know, numbers of women attending screening in their 80s. Now, to be able to self-test with either a vaginal or a urine tests are also showing promising results, and especially in older women as well. The results look, you know, they look to be as sensitive as a clinician taken sample. So, and I think that's because of the barriers and the physical barriers of taking a sample. So, and the interventions that we've heard earlier today, that, I mean, they sound incredible, just to focus on increasing coverage. So, so for a start, I think we can definitely do better than 30%. Secondly, treating HPV positive women. So those that are diagnosed with SIN will be treated and will prevent many future cancers, but also women with persistent HPV infection may choose some sort of treatment, radical treatment. And if women choose instead to be retested, say every year or so, it depends on the triage being used, but it may not prevent future cancers, but it will certainly diagnose them earlier and certainly prevent deaths. And lastly, want to say a little bit about test sensitivity, because we would expect, the vast majority of the future cancers to be occurring in women who are currently HPV positive. But it's how good is that test at picking up all the women that are HPV positive, and if women have low levels of HPV, does that matter? This is certainly an area for future research to see, how good the modern assays are. I mean, we have data from the artistic trial, which used hybrid capture too, and we found it wasn't as sensitive as a more sensitive PCR test, but how, say, the Roche Cobas does in comparison is certainly an area of future research. And these two issues in particular, they're not just relevant for designing a programme in much older women, but they're also relevant for any woman exiting the screening programme now with their final test. So that's whether women are aged 60 to 64, or if in the future the upper age is lowered, then again, these issues are pertinent to their final test. Next slide, please. So in summary, nearly half the deaths from cervical cancer in the UK are in women aged over 65. And we've predicted that there'll be around 5,000 deaths from cervical cancer over the next 30 years in this cohort of 6.5 million women. We estimate that 60% of these future cancers will be in women who have exited the screening programme with negative cytology. And the Danish catch-up programme has shown that it works really well, and they've detected a high level of current disease. And lastly, a catch-up programme in the UK would be a one-off initiative, but the protocol will be applicable to all women from now on who exit the screening programme after HPV testing. So after they have their last test, should women, for example, exiting the programme, have a more sensitive HPV test? And also, how should women be managed with HPV positivity? I don't believe that any woman should exit the screening programme who test HPV positive until they have a negative HPV test or are treated. I don't think any woman should be left and be discharged. Next slide, please. That's it, basically. So just to acknowledge my co-authors, Professors Emma Crosby and Julian Pito, who I've worked with on the artistic trial and also on this editorial, which you can read in the BMJ. And basically, yeah, any questions? I think my last slide is just a repeat of one of the other ones, if there's quite a few discussion topics on there. Thank you very much.
Thanks, Claire. That was really good. It was great to hear from you.